Welcome back to The Explainer. Okay, today we are doing an urgent, critical teardown of some seriously outdated medical practices. We're focusing on something that happens literally every single day in the intensive care unit, and that's urinary tract infection management. For way too long, our clinical habits have been driven by outdated dogma, but the science has aggressively moved on. So today, we're breaking down the pathophysiology, the diagnostics, and the critical care management of UTIs. And we're completely resetting how you should look at that catheter sitting at your patient's bedside.
I want you to answer this question honestly in your head right now. Are you still treating UTIs the way you were taught 5 or 10 years ago? If you're instinctively ordering cultures just for cloudy urine or, prescribing broad-spectrum antibiotics because a patient has a catheter and a mild fever, your mental models urgently need an update.
Okay, let's dive into this because the stakes here are absolutely massive. Urosepsis isn't just some minor complication, right? It accounts for roughly 30% of all sepsis cases. Just think about that volume for a second. And we aren't just fighting standard bacteria anymore. We are facing a rapidly surging antimicrobial resistance crisis, specifically with ESBL, extended spectrum beta-lactamases, and CRE, which is carbapenem-resistant Enterobacteriaceae. Add in the fact that catheter-associated UTIs, or CAUTIs, significantly prolong an ICU length of stay and drain hospital resources, and you really start to see the true scale of the problem. Frequent recurrences drive cumulative, prolonged antibiotic exposure, which causes immense collateral damage to the patient's microbiome. Bottom line, we have to be better stewards of our treatments.
Section 1. The Great Reclassification. Moving past sex-based criteria.
And this brilliantly illustrates the night-and-day difference between the past and the future of infectious disease management. Under the traditional approach, classification was rigidly sex-based. If you had a male patient with a UTI, well, it was automatically deemed complicated, which led to prolonged empiric IV treatment, often continuing unnecessarily right up until hospital discharge. But the newer approach, driven by the IDSA 2025 guidelines, completely flips the script to a clinical disease-based classification. We now focus on the actual extent of the infection and the systemic involvement. Yes, males actually can have uncomplicated cystitis. What this means is we can use risk-adapted, shorter therapy and aggressively push for an earlier IV to oral transition.
So this modern classification spectrum is no longer about patient demographics. It is entirely about the depth of the infection. Starting down in the green zone, we have uncomplicated UTI, or cystitis, which is strictly confined to the bladder with local signs only. Moving up to the yellow zone, we hit complicated UTI. This is where the infection breaches the bladder, involving pyelonephritis, CAUTI, and bacteremic states. And finally, the red zone, urosepsis and shock. This is a massive systemic inflammatory response requiring rapid hemodynamic intervention and broad-spectrum empirics. You categorize by the severity of the disease now, absolutely nothing else.
Section 2. The micro-battleground, biofilms and catheters.
A healthy genital urinary tract actually has a phenomenal set of natural armors. It relies heavily on a mechanical defense, primarily the flushing action of continuous urine flow that literally washes pathogens away. Immunologically, messenger proteins like interleukin-8 promote neutrophil activity, and mucosally, you've got elements like TAM horsefall protein and sloughing uroepithelial cells that actively block bacterial attachment. Simply put, the human body is naturally excellent at preventing these infections.
Now, what's really interesting about this slide is how placing a catheter entirely dismantles all of those natural defenses we just talked about. You bypass the mucosal blocks, you create incomplete emptying where residual urine just sits there, basically acting as a warm culture medium. But worst of all, the foreign body of the indwelling line provides a permanent surface for bacterial adhesion. It acts as a biofilm scaffold. It's essentially a permanent, synthetic superhighway for bacteria to colonize the bladder.
So how do the bacteria actually get in? Well, while some infections happen directly during insertion, and about 20% happen via an intraluminal route from within the catheter itself, the vast majority of infections happen via extraluminal migration. This is where opportunistic bacteria, like Pseudomonas, literally migrate right along the mucus sheaths surrounding the exterior surface of the catheter. The catheter is the ladder they climb to breach the host's sterile environment.
Section 3. Demystifying diagnostics. The Puria paradox.
Let's move to and see how this builds a completely new understanding of culture results. When we're tracing the timeline of colony-forming units, or CFU, per milliliter, the threshold for what constitutes a significant infection shifts dynamically based on the presence of foreign bodies. For an uncomplicated clean catch, you might look at 10 to the power of 5 CFU per ml. But look right in the middle there. For catheterized patients, the consensus cutoff for significant bacteriuria is just 10 to the power of 3.
Why the difference? Because those thick, dense biofilms we just talked about actually prevent higher bacterial replication rates in the urine itself. The bacteria are locked in that slime layer on the plastic, so a lower concentration in the fluid is actually highly significant.
And this brings us to a non-negotiable rule of modern critical care. Treat the patient, not the foul-smelling or cloudy urine. Isolated pyuria, meaning white blood cells in the urine without systemic symptoms, is a paradox. It is absolutely not an automatic indication for antimicrobials. You have to look for alternate causes. Reacting instinctively to cloudy urine by ordering antibiotics is exactly what drives the resistance crisis we highlighted at the very beginning of this explainer.
So the crucial point here is perfectly highlighted by the Candidaria dilemma. You get a positive urine culture for Candida species, panic sets in, right? Wrong. In the ICU context, this is usually just colonization. It is not an active infection. Your immediate action should not be to order toxic antifungals. Your action should be to discontinue antibacterial agents, minimize immunosuppression if you can, and most importantly, remove the urinary catheter. If you simply pull the hardware, funguria resolves spontaneously in an incredible 76% of patients. So do not instinctively reach for amphotericin. Reach for the catheter balloon syringe.
Section 4. The ultimate clinical rule, evidence-based stewardship.
Okay, let's do a rapid-fire teardown of the medical myths you need to abandon today. First, do not screen for or treat asymptomatic bacteriuria in catheterized patients. Treatment doesn't improve outcomes and actively drives resistance. Second, do not use antibiotic-coated urinary catheters. The clinical value and cost-effectiveness simply aren't there. Third, do not instill antiseptic agents or chemicals into the drainage bags. And finally, do not perform daily metal care with povidone iodine or topical antimicrobials. These are legacy practices that lack rigorous evidence and honestly just waste clinical time.
Let's break down a real-world clinical synthesis of this mindset. Imagine an elderly patient in the ICU. They have asymptomatic bacteriuria, but they're pending an orthopedic surgery. Now, the old-school reaction might be a broad-spectrum escalation out of pure fear, but the new evidence-based rule? Proceed with the surgery and do not broaden antibiotics. The evidence shows that asymptomatic flora rarely seeds prosthetic joints. Broadening coverage here only invites resistance and microbiome damage without actually protecting the new joint.
It all boils down to this fundamental foundational truth. In the ICU, the definitive cure for urinary tract infections relies on reestablishing the anatomical and mechanical integrity of the genitourinary tract. The truest cure is not found in a stronger, broader, more expensive IV antibiotic. The cure is restoring the body's natural defenses by pulling the plastic out of the patient.
We have completely deconstructed the outdated dogmas of UTI management today. We've seen exactly how biofilms hijacked host defenses, why cloudy urine shouldn't trigger an automatic antibiotic prescription, and why less is truly more when it comes to candiduria and asymptomatic colonization. So I leave you with this final provocative thought. Based on this paradigm shift, whose catheter are you going to evaluate for removal on your rounds tomorrow? Take this evidence, advocate for your patients, and start pulling those lines. Thank you so much for joining me on this explainer, and I'll catch you next time.